this portion of the DVD series, I will review with you the ultrasound evaluation of the shoulder. I will describe the basic technique for positioning of the patient. I will review some basic anatomy and then demonstrate the ultrasound anatomy. Finally, I will also review some clinical correlations. First of all, the techniques. When analyzing patients' shoulders, it is best to have the patient seated on a rotating stool, and the examination can be done from the front or from behind the patient. It is always good to compare both sides, especially when looking at patients with disease, comparing the normal side with the affected side. As usual with ultrasound, imaging should always be conducted in tangential planes, both a longitudinal and a transverse view. And for the shoulder, it is important to look at dynamic stability, and we'll show you how to do some dynamic examinations of the shoulder as well. The shoulder is a ball and socket joint, and it's not a single joint, but it's made of 4 separate articulations. In this slide, you can see the glenohumeral joint, the acromioclavicular joint. Not shown on this image is the sternoclavicular joint and the scapulothoracic joint, which will be posterior to this image. The 3 major bones of the shoulder include the humerus, the clavicle, and the scapula. And in this image, you can see the anterior and the posterior orientation of those bones. Let's look at some greater detail of the humerus. The humerus includes the humeral head, the greater tuberosity, and the lesser tuberosity. The tuberosities are critical because these are the sites of attachments for the bones. On the surface of the tubercles, you will see different facets. The inferior one is for the attachment of the Teres Minor, the middle one is for the attachment of the infraspinatus, and the superior one is for attachments of the supraspinatus tendons. Let's look at the scapula in greater detail. At right angles to the body, the spine projects posteriorly, separating the suprascapular fossa from the infrascapular fossa. The spine continues laterally to form the acromion process, under which passes the tendon of the supraspinatus muscle. Let's look at the major muscles of the shoulder. Remember that the muscles of the shoulder is essentially there to provide stability. This is provided mainly through the system of muscles called the rotator cuff. There are 4 muscles which comprise the rotator cuff. They include the subscapularis, the supraspinatus, the infraspinatus, and the Teres Minor. On this slide, you can see those muscles in an orientation going superiorly to inferiorly, the supraspinatus, the infraspinatus, and the Teres Minor. On the image to the right, if the patient slightly rotates, you can see those attachments of the muscles to the humeral head. This slide demonstrates to you the function of the various muscles of the rotator cuff, being able to abduct, adduct, and internally rotate the shoulders. I've also included and listed the nerves involving innervations of those muscles. If you take this image again and to remove the humeral head, you can see how the rotator cuff muscles provide stability. Anteriorly, you will see the subscapularis. Superiorly, you will see the supraspinatus. Underneath that, you will see the infraspinatus. And finally, most inferiorly, you will see the Teres Minor muscle. Now let's talk about the ultrasound. There are 9 standard scans that are done when analyzing the shoulders, and they are listed here: the anterior transverse scan, the anterior transverse scan in maximal internal rotation, the anterior longitudinal scan, and the anterior longitudinal scan in maximal internal rotation. The longitudinal scan is also performed in neutral positions and also in maximal internal rotation. And then we'll move posterior to look at the posterior transverse scan, an axillary image, as well as the acromioclavicular joint. Let's first look at the biceps tendon in transverse view. Examining is done by looking at the long head of the biceps tendon as it transverses through the bicipital groove. The patient will be seated with the hand placing up and the shoulder slightly externally rotated at 15 degrees. Let's take a look at this on the ultrasound. So let's take a look at the biceps tendon. We first have the patient seated with the elbow flexed 90 degrees and the hand in supination with the palm facing up. Remember from the basic anatomy that the biceps tendon transverses through the bicipital groove. You also want to be sure that you keep your orientation such that the left side of the screen represents the medial portion of the patient's body. As we scan the image here, I like to have the maximal focal point on the humeral head. You can see this hyperechoic area is the humeral head. Above that, in the bicipital groove, which is this indentation here, you can begin to see the biceps tendon. The biceps tendon is stabilized in the bicipital groove by the transverse humeral ligament that you can see going across. So to review, this is a humeral head, the bicipital groove, the biceps tendon and transverse orientation stabilized by the transverse humeral ligament. Remember, you also want to evaluate all structures in two orientations. So now we will look at it in longitudinal view. And simply, once you have the tendon identified, remember to stabilize the transducer and slightly rotate it to 90 degrees. And what you're able to see here again is the biceps tendon in longitudinal view. Here you will see the head of the humerus. Above this is going to be the deltoid muscles. If this patient had effusion, swelling, or increased inflammation, you would also see some changes in elevation of the biceps tendon, and I'll show you some clinical examples of that later. We will next take a look at the subscapularis, one of the components of the rotator cuff. If you look at the anatomy slide here, remember that the subscapularis is just medial to the biceps tendon. It is best visualized with the patient's arm relaxed at the side and with the thumb pointing toward the front. The subscapularis should also be visualized with the shoulder in maximal external rotation, which is because it's an internal rotator of the shoulder muscle. So I have the patient's arm hanging to the side with the thumb pointing to the front. And to get your orientation, you may go back to the biceps tendon, which we see here in transverse section. Here's the humerus, the head of the humerus, and the bicipital groove. I want to move just medial to that to where we will see the subscapularis. So if you follow your ultrasound image, the next tendon that you will begin to pick up is going to be the subscapularis. So this is the subscapularis in transverse view. If I were to rotate the transducer 90 degrees, we will visualize that tendon and longitudinal orientation. And here it is. Notice the position of my transducer, and you can see the image on the screen. So here is the humeral head, and here's the subscapularis as it comes over and attaches to the lesser tubercle. Let's now take a look at the acromioclavicular joint. To visualize the acromioclavicular joint, the transducer is positioned parallel to the lateral third of the clavicle. It is moved from anterior to posterior in the same plane as the joint for optimal imaging. The superior ligament may also be seen in some patients. Evaluation of this joint is very limited. It is a site for certain conditions such as rheumatoid arthritis. So again, the patient's arm is relaxed at the side. As we identify the clavicle, you want to go to the distal third, right at the junction of the acromion. This is a very superficial joint, and when scanning it on the ultrasound, it is best to be at a high frequency. In this case, I have the transducer frequency set at 12 megahertz. I first capture the bony image of the clavicle and follow that out to the right. The lateralmost bony image is the acromion, and in between is the acromioclavicular joint. I'm going to zoom in on that joint for just a moment. In some patients, you might see a small amount of synovium, and definitely if a patient had some inflammation, that would be thickened. But again, going medial to lateral, the clavicle, acromioclavicular joint, and then the acromion process. In some cases, as you go just over the acromion, if there's some inflammation in the region of the subacromial bursa, you will identify a pocket of fluid in that area. Let's next take a look at the second muscle involved in the rotator cuff, the supraspinatus. Position of the shoulders is important for this particular examination. Here you want to have the patient's shoulder extended, internally rotated, and abducted. To do that, what we essentially do, we'll have the patient imagine them attempting to touch the opposite scapula. What this does, it extends that area so you can very nicely visualize the supraspinatus tendon. So again, we will use one of the higher frequencies, either 10 or 12 megahertz, to visualize this. As you see on the machine, we want to attempt to focus on the bony landmarks, which in this case is going to be the humeral head, which you can see here, and then you will see that anechoic region of the articular cartilage of the humeral head. Above that, you see a nice large tendon, which is the supraspinatus. Remember from the basic anatomy that the supraspinatus attaches to the superior tubercle on the greater tuberosity. And as you follow that laterally, you can begin to see that attachment. Now, if you notice, I do begin to get slightly off the shoulder, giving you this anechoic region, so the black area here where the transducer is not contacting the skin. But in this region, where the attachment is, this is critical because if there was an injury or a tear of the tendon, that will be the point where you begin to see some thickening and possible effusion of that region. So again, the humeral head, articular cartilage, and the supraspinatus tendon in transverse view. Keep in the same position and rotating slightly, we should be able to image the entire length of the tendon and better illustrate as it attaches to the greater tuberosity of the humeral head. So again, going inferior to superior, the humeral head, articular cartilage, and then you may see the border of the supraspinatus tendon. I'm going to follow that medially, and you can begin to see the thickness of it. And when you're evaluating this, you want to look at if there's any change in the density or the echogenic signal throughout the entire thickness of the tendon. Keeping the patient in the same orientation, we will look at the third tendon involving the rotator cuff. So we've taken a look at anterior subscapularis, we've looked at the supraspinatus. I will now look at the infraspinatus. The infraspinatus, remember, lies in the infrascapular fossa. This is where we were for the supraspinatus, and if we go just slightly inferior to that, we begin to see another thickened tendon. Again, focusing first on the humeral head, the articular cartilage, you can begin to see the nice fibrillar pattern that comprises the infraspinatus tendon. As we follow that along, remember the infraspinatus tendon attaches to the middle facet of the greater tuberosity. So again, the humeral head, articular cartilage, and the thickness of the infraspinatus tendon. Let's now take a look at the final muscle that comprises the rotator cuff. We have shown the subscapularis, supraspinatus, infraspinatus, and now we will look at the teres minor. The teres minor, as you can see on the slide, lies inferior to the infraspinatus, and it attaches to the inferior tubercle of the greater tuberosity. So as we first focus on the humeral head, we can see the articular cartilage, and then above that we begin to see this fibrillar pattern involving the teres minor. If we follow that along laterally, we can just begin to see it before we lose the signal where it will attach to the inferior tubercle of the greater tuberosity. And then we can simply spin around on that 90 degrees to look at it in the other orientation. So here we begin to capture the humeral head, the muscle, and then the tendon associated with that. Remember, Now that we've analyzed all the structures of the rotator cuff, let me point out a few other important points. I have now focused again on the infraspinatus muscle. Unlike structures such as the fingers, where they're very superficial, for the shoulder, you're going to be looking at structures that are deeper. So therefore, you want to adjust the frequency of the transducer appropriately. So if I capture an image of the tendon over the humeral head, I will use a freeze button to hold that image. So for the shoulder, we would recommend using a frequency in the range of 10 to 12 megahertz. You also want to have your depth appropriately adjusted as well. So here, the maximal depth point and the point of focus should be on the area of the humeral head, because this is indeed where the attachments of the tendons of the rotator cuff are. You can actually change your focal points, and you can measure those distances as well if needed. So the critical things here when looking at structures such as the shoulder is looking at the appropriate frequency, adjusting your depth, and also adjusting the gain accordingly. Those are critical for examining the shoulder. Let's now take a look at the glenohumeral complex. The glenohumeral joint is also another critical joint that may be involved in the sites of particularly things like osteo and other types of arthritis. With the shoulder exam, we've done a lot of moving around of both of the patient and also of the transducer. It's very critical that you don't lose your orientation. One of the nice things about the Logic E on the 12L transducer, you have a groove, and that has actually been preset so that that groove correlates with the medial aspect of the body. So you also always want to make sure you have that orientation. So in this case, we're going to have the patient's arm with the elbow flexed 90 degrees, and then we're going to extend it out so that opens up the glenohumeral joint and that glenohumeral complex. Again, because it is a deeper structure, you want to have the frequency of the transducer set at 10 to 12. And in this case, I have it set at 12. So as we look at here, we will see superficial structures. We're going to see the deltoid muscle, and then we begin to see two hyperechoic structures that's going to represent the glenoid and the humeral head. The glenoid is going to be medial, and the humeral head is going to be lateral. You can also do a dynamic examination of that joint, having the patient to internally and externally rotate the arm, and you can actually see very nicely that complex. One of the other nice features about doing a dynamic examination as the model continues to move the arm back and forth, if there were any spurs, if there were any loose bodies, if there was any calcifications, all of those could be captured and seen in that area. In her, since she's a normal individual, you see a nice articular surface, and that you see the labrum is nice and thickened. There's no tears. There's no hypo or anechoic regions within that area. So this is a glenohumeral joint, looking at the anterior portion of that. So now that we've seen the anterior portion of the glenohumeral joint, let's take a look at the posterior portion of that joint. Here we will have the patient seated, and we'll have her to actually touch the other or opposite shoulder. This extends the glenohumeral joint. In some patients, particularly if they have well-defined muscles, it might be difficult to see the specific borders where you want to identify and looking for any pathology, which is the posterior glenohumeral labrium. Another way that this can be done from the patient's axilla to look at that as well. So with her, we can begin to see the portions of the humeral head, and then just to the right of that would be the area where the glenohumeral joint and that complex will be involved. It is not usually a site of much pathology unless a patient had a specific injury as a fall to the shoulder. But this would be the region that you would look in. In rheumatology, I find that the anterior glenohumeral joint is more involved, particularly with things like osteoarthritis. So that concludes the glenohumeral examination. The shoulder examination is a detailed examination and might take some time to really master the examination. With that being said, there are still some abnormalities that might even be shown from a beginning person doing ultrasound evaluation of the shoulder. These are some of the features that might be seen with the ultrasound. They include effusions, tenosynovitis, ganglions, rheumatoid nodules, looking for bony pathology such as erosions or spurs, calcifications, and other areas of crystal deposition. Here are a couple examples. This is a patient that had anterior shoulder pain, and when the ultrasound was performed, looking at the biceps tendon, you see on the left here a longitudinal orientation of the biceps tendon surrounded by anechoic region, which included effusions. When the transducer was rotated 90 degrees, you could see the biceps tendon in transverse view. You can see the head of the biceps tendon in the middle, surrounded by this black or anechoic fluid. So this represents a peribicipital tendonitis. Sometimes you may actually see inflammation associated with that. And this is the case of another patient with anterior shoulder pain. You see the tendon surrounded by an anechoic region. On the left is a B-scale mode, and on the right is with Doppler enhancement, showing that indeed there is some inflammation. As we showed you earlier, the supraspinatus tendon is the one that's most commonly involved in rotator cuff injuries. So it is critical when you're performing your examination of the supraspinatus, you look at a region which we call the footprint region, or that critical zone. And that is roughly 1 to 1.5 centimeter regions of the tendon, just as it attaches to the greater tubercle of the humeral head. So you always want to focus your areas there and then begin to work back away from the area to looking for signs of a rotator cuff tear. That would be identified as areas of anechoic or hypoechoic signal. In some cases, you might see some inflammation around that area as well. The ultrasound is very good at looking at erosions of the shoulder. This is a patient with rheumatoid arthritis, and on the left you can see that there is an erosion involving the humeral head. Another orientation is shown on the right side of the slide. So even though it may take several months to master the complete shoulder examination, I think that even people who are beginning to perform musculoskeletal ultrasound are able to identify bursitis, synovitis, and even spurs involving the shoulder joints.